Hello, everyone. Thank you for joining and breaking out into this session on technology for telehealth. And we'll go ahead and get started now. So, today, some of the learning objectives for this technology and telehealth session are that as a participant, you'll be able to describe necessary software and infrastructure for effective telehealth service delivery of HIV clinical services, identify potential HIPAA compliant technology that can be utilized for health. Telehealth delivery and describe upcoming technological advancements and opportunities for telehealth, specifically with COVID 19, which is exciting. So I wanted to just remind you that if you do have questions for our presenters, there will be a designated time at the end of the session for open Q&A, and you can take your mic off mute. But in the meantime, if you have any questions or you're more comfortable utilizing the chat box, please feel free at any time to chat our presenters or chat myself as the moderator today and ask questions that we can answer during the Q&A at the end. I want to go ahead and introduce our two really great speakers that we have today. We have Dr. Madhuri Ladd, and Dr. Ladd is the Assistant Medical Director at the Oklahoma State University Internal Medicine Specialty Services Ryan White HIV Clinic. She is the facilitator for the OSU HIV Project ECHO and also is certified in treatment of HIV. Her position on the Tulsa Cares Board, which is a nonprofit organization that provides services to persons living with HIV in Tulsa, keeps her active in the HIV community in Tulsa. So, welcome, Dr. Ladd. Dr. Snyder also is joining us. He received his PhD training at the California Institute of Technology and carried out his postdoctoral training at Stanford University, where he now is the chairman and professor in the Department of Genetics and the director for the Center for Genomics and Personalized Medicine. He is a leader in the field of functional genomics and proteomics, and one of the major participants of the ENCODE project. For the past decade, he's been using longitudinal tracking and measuring everything about human health to predict and prevent disease ahead of time, including COVID 19. So hopefully I pronounced all of those words, but I'm sure Dr. Snyder can correct me if needed. So without further ado, I'm going to turn it over to Dr. Ladd for her presentation, and thank you all for joining.
Infrastructure. Like I said, this telehealth program that we're talking about today is a little bit different than virtual visits. So I'm really excited talking a little bit about what we do. We'll talk about HIPAA compliant technology and not, and then some further opportunities and advancements. So this is our clinic here in Tulsa, Oklahoma, and we have been here since September of '96, but actually done telehealth through here since 2014. And Oklahoma being a rural state, the necessity was there. And that's the reason that we started doing telehealth at that time. And we've cared for patients, over 3,000 patients since '96, and we are part of a Ryan White funded clinic here. Next slide. Our distribution in the state is divided right in half, east and west. There's 2 Ryan White clinics in the state of Oklahoma, and we take care of the orange section, OSU, on the eastern half, and the other takes care of the western half. We're a little over 1,300 patients, but as you can see, there are patients that may need to travel quite a ways to be able to reach us, and oftentimes having to drive 2 to 3 hours, and so really taking transportation as a barrier and being able to reduce that with telehealth is the main purpose of us starting the telehealth program and why we're kind of having the discussions today. Next slide. We do have 2 locations that I currently do our telehealth program. I reside in Tulsa, and my team is able to do telehealth through Podo and McAllister, are the 2 towns. Podo is about 2.5 hours away from Tulsa, and McAllister being about 2 hours to 2 hours and 15 minutes. So it really does save patients quite a ways, quite a distance, especially when I have patients sometimes that aren't able to have a mode of transportation, or maybe even being able to afford the gas money to transport to Tulsa on a regular basis, especially if we're seeing them every 3 months for routine HIV follow-up. So being able to provide telehealth really is helpful for those patients. So I thought we'd start with a patient case. So next slide. And I'm just going to talk a little bit, real briefly, about how we're able to utilize telehealth to be able to help a patient such as this. So this was a 55-year-old male that I've seen on telehealth for a while. He's HIV positive and living out in Poto, Oklahoma. And the biggest barrier for him was transportation. So he was one of the first patients that we enrolled in our telehealth program. At that time, he was on atazanavir or Rayataz with Norvir or ritonavir, and then Descovy, TAF, and drosanamine. His CD4. So he had some labs done at the outlying lab, so we wouldn't have to transport to Tulsa to do that. And I was able to get the labs, review them. They're scanned into his chart. And so I can review those for the telehealth appointment. His CD4 was 300 and viral load undetectable at that time. But he tells me during the visit that he's also had a cough, and he just recently was seen at a local urgent care, was placed on azithromycin and some Flonase or fluticasone nasal spray. And those were just prescribed the day before. And he also says, well, by the way, I also have this itchy spot on my right leg. So how can we use a telehealth appointment to really look at all these things for this patient? So we're conducting the telehealth appointment today. I am in Tulsa. We're utilizing Zoom. My nurse is at the outlying facility. She's able to take his vital signs, go through his med reconciliation, and really go through the rooming process like we would in our Tulsa clinic, and be able to update all that information into our electronic medical record, which is Epic. So I have the labs in hand. They're scanned into his chart. We talk about prescription refills. I'm able to e-scribe them to his local pharmacy. And then we go over medications and his labs, and we go over saying he's undetectable, everything's going well. But happen to notice there's an interaction between his Flonase and the Norvir ritonavir that he's on. We're able to talk about how we can make that dose adjustment, and that he should be using the Flonase at a different dosing because he's on the Norvir. We're able to talk to him about that during the telehealth visit. I'm also, because of his cough, able to use my stethoscope to listen to his lungs. So I'm going to show you a little bit about how we can do that. But my nurse is basically able to use the Bluetooth stethoscope on her end. I'm able to hear that through my headphones and able to listen to his heart and lung sounds. And then we're also able to utilize a dermoscope because he did have an itchy spot that he wanted me to look at. And so we were able to do that utilizing the dermoscope, and I was able to diagnose that he had tinea corporis and be able to prescribe treatment for that, all on this telehealth visit. So how did we do that using telehealth? Next slide. We've talked about some of the barriers here. We talk about these at each appointment with patients, and oftentimes transportation is a barrier. So we've kind of talked about that. Next slide. I'm going to show you our mobile unit. So this is our telemedicine bus that we've used for several years. And what we used to do, this is the bus that used to go out to McAllister and Poto with the nurse, and I have a licensed driver of the bus who is also our IT person, is able to help with the technology. Those are the only two staff members we used to send out with this bus to the rural areas. Next slide. I'll show you what the bus looks like in the interior. We have a waiting, not a waiting room. The waiting room is really in patients' cars. They'll come up when it's their turn, just so we can make sure that it's a confidential appointment. This is the front desk area where they'll check in and get their vital signs done. And you can see that there. And the next slide will show you our patient room. And they can also have their medication reconciliation done in this area. And this is where I can also do my physical exam and be able to see them on the screen. Next slide is just really our computer that's there. We have not only our electronic medical record there, but also our stethoscope program and any other programs that we may need to be able to conduct the visit. Next slide. So just looking at different technology, when we look at different platforms really that can be utilized, I'm going to just show the two that we've utilized with our program, Polycom and Zoom. So Polycom is actually a camera, and this is what we initially used to utilize. A very high quality camera, excellent picture, quite expensive. It was about 4 to 5,000 for the unit, and in addition to that, also required a fee, annual fee that had to be also paid. It was a little bit more difficult to set up and use, so the ease wasn't as easy as things such as Zoom is now. And it did require quite a few updates. And then also had limited uses, so I could only use it for telemedicine, wasn't really using it for anything else. So then we ended up switching to Zoom, and we found that it was more cost effective, very easy to use, and very HIPAA compliant. And then really could be utilized from anything, a desktop, a laptop, even a tablet or cell phone, if need be, if connectivity issue becomes a problem, as it very much can in rural Oklahoma at times. So it was requiring less equipment, and we all know the multi-purpose platform. Everybody is familiar with Zoom these days, and even though sometimes can cause technological challenges as we had today, it really can be user-friendly. Next slide. So next is some of the equipment I can use. So how can I examine these patients on these telehealth appointments? We actually have scopes. Our scopes are horoscopes. That's just the name brand. But I'm actually able to use this. My nurse will utilize this on her end with the patient. She's able to put this in the patient's ear, for example, when I'm wanting to look at their tympanic membranes. She can see it on the screen that you see attached to the otoscope, and that image is then projected on the screen. So the picture in the right-hand corner is what I'm able to visualize on my end, all from that telehealth visit. Next slide. It's also important for me to be able to look in their mouth, because many times I'm wanting to make sure that we don't have thrush, even in my patients who had intact CD4s. And so this is just the general scope. The otoscope is an attachment. This is the general scope, so I can take a look in the mouth, and you can see there what is projected on the screen is actually what I see. And the next slide will show you the other scope attachments, but one of those also includes the dermoscope. Next slide. And so that was how I was able to actually look at the patient's tinea corporis and diagnose them with otherwise known as ringworm, and be able to treat it so easily. Otherwise, on the main camera, it might be kind of harder or more difficult to look at a rash that's pretty small, like ringworm might be, but the dermoscope can actually magnify that and make it better to visualize. Next slide. So looking at cost, so the cost of some of these things, we all know that Zoom is pretty cost effective, and but when we start looking at some of this other equipment, the pricing can add up. So the scopes oftentimes can come in a bundle, the general scope with the otoscope and dermoscope, and runs close to about $6,500, around $6,000. And then there is just an additional fee for the service, around $600 to $650 there. Next slide. And then remember, we also have the stethoscope program. So this is the original stethoscope program that we utilized when I first started participating in telehealth. And this program was good. We were able to hear heart and lung sounds well, but it required a lot of updates. And it seemed like we only go out to these locations. We used to only once a month. Now I go to each of those locations twice a month. So essentially every week we're going out. But when we were going less often, we would find that every time we went to use the stethoscope, it required another update. And so we decided to look at some other programs, which I'll show you. But just to look at this program's cost, next slide will show you a rough estimate of the cost, the stethoscope being probably the most expensive. Now, because we're a larger university and other areas doing telehealth within the university, we had ordered a quantity of 10. But if you look at the quantity of one, it was $386 for the stethoscope, and then required a Bluetooth adapter. So that was just a rough estimate of one unit of the stethoscope. Next slide. But here you can see that we also needed to pay for the software so we could utilize the program. And again, here's the quantity of 5, but a quantity of 1 would be $750. Next slide will show you the program that we switched to, and we utilized this for a while. This was nice. It's called Think Labs, and you could actually use it with an app on your phone or a tablet. And I could not only capture the sound and listen to it live, but if we had technological issues during the session, my team could also record it and save it and send it to me on my mobile device, and I could then listen to it within a matter of seconds. So this was a nice feature of the Think Labs. And then, of course, they could share the sound with me after recording through email or a text message. So usually they would just text it to me. Next slide will show you the cost of this program. Not too much different than the previous, about $500. It worked well. It did require a few updates, but not as many as the first program. I thought overall it worked well and we would have managed with it. But part of the university, some other departments are also utilizing the scopes, and particularly our cardiology department was interested in something that would also give some EKG readings. So we switched to, we'll go to the next slide, we switched to the ECO program, which now not only can I listen to heart and lung sounds, but we can also see EKG readings. And so we have now switched over to this, only been maybe about a month or two that we've been utilizing this program, but the sound quality has been excellent, has worked very well. We haven't required many updates. It is HIPAA compliant. And the next slide will show you as we take all this, we want to talk, also about the price of the eco. So it was a little bit more expensive. The expense was really the annual cost, which was $1,200 for that annual cost of the program. And then you can see there just the cost of, there's two there. The initial quote on the left is just the stethoscope itself if you only want heart and lung sounds. But if you want the EKG and be able to see that as well, then there's a slight additional cost on there on the right. Next slide, and this, I'm sorry, is a little bit small, but essentially just looking at if you wanted to put all this equipment on a cart, you'll see telemedicine carts sold, and they can be fairly expensive, but you can create your own cart, which we've done here recently with some of our equipment that we already had. And so it just shows you some of the connections that you can make. You want to make sure you have a computer or laptop on the device to be able to connect to all these things utilizing the programs. The cost of a telemedicine cart on the next slide will show you one example. And these can get fairly expensive when you buy them all together already formed. This is a Polycom cart. So I showed you a Polycom camera earlier, and that camera is very high quality, but can also be fairly expensive. So I just pulled one up just to kind of show for an example. And I can show you a little bit of the price difference of what we did versus buying one outright. Next slide will show you that cost difference of the equipment. And I broke down our equipment costs with the cart and the monitor, a stethoscope program, even let's say we wanted to splurge and have the EKG part, our scopes, and the expense of those, and then just the nominal fees for Zoom. So came to roughly about $13,000 versus a $48,000 cart here. Even if you added the Polycom camera, if we weren't going to utilize Zoom, we could still keep that about $18,000 compared to the cart already formed. Next slide. So what kind of staff does it need? So when we had the bus, we required the telemedicine bus driver who was also, he was licensed. He needed a commercial driver's license for the bus. And he was also our IT guy. So he was familiar with all the equipment, all the software, even the scopes and everything. So he could help train my nurses. I do have a designated nurse for telemedicine. And then we usually have somebody kept for backup just in case. And that person needs to be familiar familiar with the electronic medical record as well as the equipment and how to use it. And then the physician needs to be competent in terms of equipment as well as coding. I'm the only physician at our facility that does telemedicine, but I am currently training other nurses in the outlying facilities to be able to do what my nurse does for telemedicine, to take out the fact that right now we have to take 2 staff members and send them out. And now that we're doing telemedicine weekly, think about the time that goes into them driving out to the facility. They oftentimes leave very early. Our sessions start at 8:30, so they're leaving usually 3 hours prior to that, so they can get there and set up. And then that turnaround time to come back after we do a morning clinic until noon. So it could really be an all-day experience. We thought, can we manage this by actually training staff at the outlying facilities, and instead of using a bus, utilizing concrete brick and mortar locations at these facilities. So I'll go into a little bit how we were able to do that. Next slide. So before we do that, I wanted to just talk about some of the challenges that have occurred with the way we were doing telemedicine. Of course, we've got to think about weather, and weather in Oklahoma overall not bad, but sometimes we do have some iciness or snow that can make it difficult for the bus to maneuver in the winter months. We can also have mechanical issues. We've had the heater go out in the bus before, and other maintenance and fuel costs. So these are just some things to think about if you're thinking about utilizing a mobile unit. Wi-Fi and stethoscope connectivity. So remember, we're going out to rural Oklahoma, and sometimes we can have connectivity issues, or it can even be where the bus was parked. If it was parked behind a building or large trees, we could have connectivity issues. If the weather had problems that day, we could have issues. So we've got to think about all those things. Software updates could be challenges because sometimes we were finding we were having to do those updates more often than we'd like. Inexperienced staff. So remember, we've got to make sure staff knows how to use all the equipment, and usually having a backup person found that is very helpful because everybody has days that they may be sick, and we don't want to cancel a whole telemedicine clinic for that. Canceled appointments or no-shows. Remember, if we're going out once a week or once every 2 weeks, we have a schedule just like you would when you're seeing patients in the clinic. And if you have a lot of patients who don't do their labs and we end up canceling, then it could get in the way. So you don't want to send 2 staff members out to see 2 patients, essentially. Secure location of the bus, referrals in rural areas. Remember that when we do a referral, they may not be transporting to Tulsa to do that. So need to be familiar with the referrals in rural areas. Time spent, we talked about that. So next slide just goes over how to overcome some of those challenges. And so we've talked about some of these things, but we did utilize a Wi-Fi hotspot, even trying direct cable connections to a local network. All of us have different cell phone providers just in case connectivity goes out and we need to use our cell phones old-fashioned way. We could still utilize that. We've done the software updates, updated some of our equipment, educated our staff, and really now we're able to get rid of the bus, and we're actually contracting with hospitals to use building space for telemedicine. Next slide will show you our POTO location, and we were actually able to contract with Eastern Oklahoma Medical Center, and now they give us building space to be able to do that. On the next slide, in McAllister, we were actually able to contract with a federally qualified healthcare center, Caring Hands. They've been a wonderful organization, great relationship, and this is the space we're utilizing now. They have allowed us to use their own space there. They have a designated room for us, and so they also do primary care services in their area, so we're able to share some of the treatment. If they need primary care services and need to be seen for a cold, they can be seen in person as well at that facility. So it's a great relationship. And I do encourage people to use FQHCs if you're thinking about contracting to do telemedicine. Next slide. We talked about some of those connectivity issues. For time, I'll go ahead and go to the next slide. Pros and cons of telemeds. Convenience, affordable, and it saves time in transport. Could be a big barrier for patients. Cons, remember we talked connectivity issues, loss of a personal touch. It's still different than seeing a patient in person, being able to shake their hand and give them a hug. Difficult for complicated cases, so it's still hard to do things like, if somebody tells you that they're suicidal on a telehealth visit, it can be very challenging. And a limited physical exam, so abdominal pain or back pain can be hard to examine on telemedicine. So those are just some of the examples there. Next slide. So some of our future goals, a big one has been contracting with outlying facilities and FQHCs. Other thing we've been able to actually bring is looking at doing counseling sessions or therapy sessions using telemedicine in Poto and McAllister. And then I've actually launched a test and treat program a little over 2 years ago, and we're actually utilizing our telehealth program to do test and treat. We got some funding in September, and we've started that program. So we're doing some new and innovative things with our telemedicine program, coordinating with FQHCs. Our goal is to start a third location, hopefully somewhere in the section of Eastern Oklahoma, and of course, sharing my experiences with other programs. Thank you so much for having me today, and I'm more than happy to answer any questions at the end. I'll go ahead and send it back over to Marissa.
Thank you, Dr. Ladd. And I'm going to just quickly transition it over to Michael Snyder because I know we're already past our allotted time, but we do appreciate if you're able to stay on to join us. So I see Mike Snyder's up, and we will go ahead and get started. Dr. Ladd, if I can ask you to just mute your line and your video, that way with the recording, we can see Mike's face. Awesome. Thank you so much. And I'll let you go ahead and get started.
All right. Well, thank you. If you want, you can shift the host over to me, and I can probably be I trimmed a few slides because I knew we were running late, but if not, we'll go this way. All right, folks, I'm going to tell you about what's really going to be using advanced technologies to better manage people's health. And this is very much in the research phase, but it's actually rolling out. You'll see we're rolling out right now and trying to enroll millions of people into our study for early detection. Just by way of background, next slide. I think you all know we're in the midst of a pretty serious pandemic, and it's obviously skyrocketed to the point where there are 300,000 new cases a day and 3,000 people dying each day in the US alone. And so if you think about it, next slide, the way we're currently testing for COVID-19 is that typically people are near someone who's infected, or they themselves may have symptoms. They get tested. It's typically done maybe once a week, twice a week in some of the more frequently tested places. But the return of results is generally pretty slow. The tests themselves are somewhat expensive. It's true they may drop to a few dollars at some point, but right now, if you look at LabCorp and such, about $100 a test, somewhere in that range. So we've been exploring all kinds of new technologies for trying to better manage people's health. And the next slide is the one I'll talk about today, which is wearable technology. So many of you probably know that there's lots of different wearable devices out there. I'm going to mostly focus on smartwatches. They're worn by millions of people. There are, believe it or not, 50 million people in the US alone who wear a smartwatch. And that's roughly 21% of the US population. They're very, very powerful because they make hundreds of thousands of measurements on you every day. And they measure all kinds of different things. Next slide. So for example, they'll measure your heart rate, your activity, skin temperature. You can even measure your galvanic stress response. And the latest devices measure blood pressure. And again, all kinds of different things. Depends on the different device, and they have different resolution. So we think they're very powerful because they're measuring you 24/7. And if we go to the next slide, what they let you do is actually follow people's background measurements. So to put this in perspective, we've actually been running a research study for 10 years now. It's on average 8 years for a smallish group of people, 109 people. We've been profiling very, very deeply. We've been sequencing their genome, and we're making literally tens of thousands of molecular measurements out of their blood, meaning measuring all their RNA and proteins and immune molecules, cytokines and such. We also measure gut microbiome. do deep clinical testing, other things. But if you look in this over to the left, one thing we started adding about 7-8 years ago was the idea of wearable devices. And by doing this deep profiling on people, even just from the first 3 years of study from 109 people, next slide, we found 49 major health discoveries. And it was no one technology that found these things. Sometimes it was sequencing their genome. Sometimes it was some of the molecular measurements. Sometimes it was imaging, and so on and so forth. And some of these were a pretty big deal. Now, I should point out it's a bit of an older cohort, 53.4, which is why we think half of folks had some sort of issue that popped up during this time. But we did catch someone, for example, with early lymphoma, 2 people with pre-cancers, 2 people with serious heart issues, metabolic issues. We're in big interest there. And some of them were, in fact, picked up with wearables. We found one person who had AFib that was picked up with a smartwatch, another person with sleep apnea. And actually, the way we got into the infectious disease space was by finding someone with Lyme disease. We caught that with the wearables. And the story behind that's on the next slide. It actually turns out it was me. I'm one of the study members. And the way we picked this up, I won't get into this much detail, but we noticed that there was when I was flying to Norway 2 weeks after helping my brother put up fences in rural Massachusetts, I noticed on a flight from Frankfurt to Oslo, the last flight, that my blood oxygen was abnormally low. And from my smartwatch, I noticed my heart rate was abnormally high. That's on the right side. And I later learned my skin temperature was up. And those last things were measured with the smartwatch. And so, and they popped up even before I had symptoms. And then later I did get signs of illness, and I went to a doctor and he pulled blood, and I warned him it might be Lyme disease. And he recommended penicillin. I said, no, I need doxycycline. Got a little tense. He did give me doxycycline, and I did take it for 2 weeks. And when I got back, I got it cleared up right away. When I got back, I got tested, and I was Lyme positive, and I had given blood before I left. I was negative. So we know for sure I seroconverted during that time. So the point out of this is that I could tell, I first identified my illness from Lyme disease from a simple smartwatch and a pulse ox. So that led us, next slide, to looking at a lot of data on me and other people. And I'll just jump to the punchline. There were 4 times I was ill during 2 years wearing the smartwatch, and other people were wearing these devices as well. And every single time I got ill, including one time when I was asymptomatic, the only reason I knew I was ill, I had very high CRP, just like other times. Every single time I had high heart rate and high skin temperature. And so we wrote an algorithm that actually lets you figure out when you're getting ill just from your smartwatch. It works very, very well from change in resting heart rate. It doesn't work very well for skin temperature, we think, because people don't always wear their watch tightly on the skin. But what was powerful was that every single time I got ill, including the asymptomatic period, I could pick it up with a smartwatch. It's sort of shown on the right. It's a delta plot from person's baseline. You can see when it peaks up. And importantly, it showed up every single time before symptoms were there, including one of the asymptomatic cases. And it worked on me, worked on 3 other people, one of whom got sick twice. Every single time we had someone who was ill, we could pick it up. So we were building out the infrastructure on this. And as you might imagine, when COVID hit, we ramped up big time. We hired about 25 people, next slide, expanded out the study to make a COVID study, but it picks up more than COVID, you'll see in a minute. We partnered with a lot of leading companies, Fitbit, Garmin, others, very quickly enrolled 6,000 people. And what we did was we wanted it's a 2-part study. The first part's done, and I'll explain that in a minute. And we just started the second part. So what we wanted to do first is see if we could pick up COVID from a simple smartwatch. So from these first, it turns out 6,000 people, we had 32 people who were COVID positive wearing a smartwatch. And they had a diagnosis date and a symptom date. And then we looked to see if we could pick this up with resting heart rate, which is, and steps, that was the only available data that would give us. Next slide. This is our very first person. And what you'll notice at the top, you'll see the purple date sort of towards the right. That's the diagnosis date. The red date is the symptom date. But if you notice, they had a big jump up in resting heart rate. You can't miss that signal. 9.5 days, starting 9.5 days before symptoms. And so again, it's a very, very strong signal. And then we wrote an alarming algorithm I'll tell you about in a minute that can follow people in real time and show this big jump up in heart rate. It's actually only 7 beats a minute. It's not that big, but it's because you're making so many measurements, you can't miss that signal. And so bottom line is, for this person, they've been running around, potentially spreading illness for 9.5 days without knowing it because they were asymptomatic. So it turns out, next slide, the algorithm works on basically 26 of 32. It did not work for everyone. And we know for some people why that's the case. There were 3 people had severe asthma. We think they're on medications. We couldn't get a stable baseline. But for most people, it's pretty easy to get a stable baseline. And then you can see this jump up in heart rate. And it turns out, next slide, it turns out that it's a median of 4 days. If you look at the left, median of 4 days before symptoms, we can pick this up. And it's not uncommon to find cases where there'll be 10 days or more where they've had this jump up in heart rate, again, before symptoms appeared, 7 days before diagnosis. And it's not specific for COVID. It does show up with other respiratory viruses, and that's about 2 days before symptoms. And that makes sense because COVID, of course, has a longer asymptomatic period. So it's logical that that would be 4 days ahead of time. So we've now, so we got this all working, tuned our algorithms, and showed it could work. And I'll show you in a minute, it's not just resting heart rate, other things show up too. So next slide, what we did then was we basically set up now a real-time alarming system. And we've tuned the sensitivity to go off every 2 months. So it's a trade-off. You can either have it super sensitive, but then the alarm goes off a lot, or you can make it less sensitive and the alarm goes off less frequent. We like the idea of 2 months. We thought was reasonable, people could live with. Basically, what we do is we build a baseline of your baseline measurements, and we follow you hour by hour. And if you have several hours where you've jumped up several standard deviations higher than your normal background, we will find that from resting heart rate, and can also add a little bit of a step signal too. And so the top case shows, another person we detected. I think that one's about 9 days early. The second row shows, if you look to the right, another case, that's a COVID case. There are other things that trigger the alarm. I mentioned before, other viral infections will do it. For 4 out of 7 people, they had what we call a holiday bump. They did have a jump up. That could be due to stress, could be in-laws or something. We do know that alcohol will trigger it, not just 2 drinks at a meal, but if you really tie one on and you're hungover the next day, that will increase your heart rate. If you run a marathon, that your heart rate will be up for a few days. But if you just do a run or something, that you need enough hours of very elevated heart rate. And again, it's resting heart rate. So we can pick this up. The bottom left shows other illnesses do it. And healthy people will have these alarms as well. And again, they may be asymptomatic viral infections. They could be stress. It's not clear. So in the second phase of the study, we just launched this. And initially, we set this up for Fitbit. Now it works for Fitbit, Apple, and Garmin. We can tell we're following you. And our goal is to enroll 10 million people. So we have several thousand already. And I can tell you it's already working. We just started in December. We can see people whose alarm goes off. And next slide, it'll show up on your smartphones. I forgot to say, so we built an app that pulls in all your data, can display all this information, not just wearable data, but actually your microbiome and other clinical data too, all on your smartphone if you want. And we built this system. I won't have time to get into it because it's getting a little late, but next slide. We built this system in a way to scale, so it's highly secure, very encrypted, but can follow millions of people in real time. And we're partnering with Amazon and others to be able to do this in Google Cloud, to be able to, again, to think about, we're trying to follow people all around the world in real time. If we see this jump up in heart rate, ping them back in a reasonable period. And so it is working. We have our first positive cases where we've seen the alarm go off prior to symptoms. And so we're now, we have just several cases so far, but we're obviously in a pretty infectious time. So the number of cases is going to rise quickly. So we'd love to have any of you, any of your patients, if you want, can enroll in our study. I put the link in the chat. All you have to do is, sign up for the study, download the app, and we will set up this alarming system for you and can tell you when your heart rate's jumping up over background. Again, it doesn't prove it's an infectious disease, but it's a trigger to say something's up. And you can contextualize information. So the next slide, if you want more information, we published a study. We're the only alarming system out there that I know of, but another group showed also with smartwatches that you can pick up when people are getting COVID infection. They didn't show pre-symptomatic, but we can pick it up early, again, in real time. And it's not specific just for Fitbits, as our initial study published. Next slide. Study got published recently showing you can do this with Oura rings, and another one just got put up on medRxiv recently with Apple Watch. So next slide. So this is now showing up with multiple devices. As I mentioned before, our alarming system now works for Apple Watch and Garmin as well. So we think this is very generalizable. If you think about it, we could have 10 million people right now with monitoring systems going on them for infectious disease. When you think about telehealth, this is exactly what telehealth is all about. We can get to very rural areas. We just got funded for an NIH grant that we hope to actually put devices on Native Americans in South Dakota who have very limited access to healthcare because they're so dispersed. Somebody asked us why the slide's so small. I guess we're at the end. Sure, you could have put it in presentation mode. Anyway, next slide. These are just my final conclusions. And if you want, we can answer a few questions. Bottom line is we can show that COVID-19, we can pick up with a smartwatch. You'll see this jump up in resting heart rate. There are even effects on steps and sleep. We build this into our algorithm. We have an online detection. It's better than 63% now, the latest algorithm, but it's pretty good. And more importantly, we built a system that can scale to millions and millions of people. We're making our detection algorithm and our system, our detection system, open source, so anyone can have access to it. And we're also, again, we can roll this out for anyone to enroll. So we want to get millions of folks. We want to get all your patients enrolled so we can alert them in real time when this happens. So next slide just shows I have an amazing team that built all this and built it quite quickly. The bottom shows a link where folks, where you can sign up for the study. And a lot of this work was led by Shao Li, Amir Maumani, Ben Rolnick, and others as well here. And I guess I'll stop there and leave time if people are still on and want to ask questions, we can do that as well. Thanks again for having us, and thank you all for staying through these interesting, challenging breakout session.
Thank you so much to both of our presenters. Mike, I think that was the first time I've heard kind of some of the information you shared. So it was great. I think it's obviously relevant and very interesting. I want to echo the sentiment that thank you for staying on. I think everyone stayed on through the transition in this session. So again, thank you for your patience. If the presenters are willing and you are interested and there's questions you want to put in the chat, please go ahead and do so, and we can take some questions for either Dr. Ladd or for Mike Snyder this afternoon. We're late already. If not, we can move forward. But I just wanted to thank you all again for your engagement and participation. Any questions? You also may come off mute to ask questions if you'd like.
Yeah, would you like us to cover? I see a few in the chat, some for Dr. Ladd and some for me.
Oh yeah, you might see more than I do since I joined late. So yes, I do see one for Dr. Ladd. Do you still send your staff or share the staff at the partner facility?
Yes, and I was able to reply back to him, but yes, for everybody. So we no longer send staff. We actually were able to train staff at both locations now in Poto as well as in McAllister. So we trained 2 nurses at each of those facilities. We've now trained the McAllister staff and actually had a few clinics being able to utilize their staff, and it has gone very smoothly. Our IT is still on hand through through, like in Tulsa, but being able to assist them if they need to push the right buttons, but they don't actually have to physically go out there, and same with my nurse. So that's really nice. In POTA, we're actually in the process of the training process right now. So our next session will actually be with the staff out there, but we've done some training now. So it's been nice because it is saving the time of my staff to be able to go out.
Great. And Mike, do you see the question from Maureen McKeon? Can the wearables detect a POTS syndrome episode?
I did see that. We have a whole separate study interesting around chronic fatigue and chronic Lyme, and we haven't tried POTS syndrome yet. That's one of those things on our list. We may roll it in with the Lyme and chronic fatigue syndrome study. So we're actually building out to try and build management tools, try and assess people's good days and bad days, and then associate activities, food, exercise, things like that, that could actually, hopefully manage people towards good days and bad days. Use AI to build personalized learning models for people. And we've shown that in other studies, we can make that work. So that is the goal. It's really to build up personalized, you collect personalized information and then build personalized management systems for people based on this kind of data.
Great. And Jennifer Carey, I think you said you had a question for either speaker, if you want to come off mute or put it in the chat. Okay, so I see that Jennifer mentioned there's a lot of great technology, but there's a big gap between what providers have access to versus underserved populations. So does anyone want to comment on that?
Yeah, I'll give you my sense. It'd be good to hear from both of us. We have different perspectives. So it turned out the smartwatches are actually pretty inexpensive. It's true, you can buy an expensive one for over $200, but you can also buy one for $99. And we're actually working with a group in South Dakota where people literally live 45 minutes apart and have very limited access to healthcare. And we are going to be putting smartwatches on this group of people. And if you think about it, they will have a monitor on them, the health monitor at all times, 24/7, that can do this. So I actually think you can scale this. That you may know 60% of the planet has a smartphone. And if you compare it with a smart watch, you've got a health sensor at some level for 60% of the planet. And so I actually think, and that the price of these things is going to drop as we show utility, I think, to about $20 or even less. So I think it really can make this much, much more affordable for everyone. Right now, obviously, there is more of a discrepancy. We're fortunate to get an NIH grant to actually work with some underserved groups. And so we are going to be purchasing watches. And actually, if you're interested in that, please do reach out to me. You can put my email in here or you can look it up. But we're happy to work with underserved groups because we have this grant and we'll give them watches and they sign up in our study and we'll be alerting them.
In terms of the telehealth that we do, because we're providing all of the equipment, the patient doesn't actually require having any phone or tablet because we're utilizing that at the facility. We have, though, I do agree with you, Jennifer, in that we've done virtual visits through our clinic, and most of the time we've utilized Doxy.me, but that has come up where either patients didn't have access to a cell phone, or a lot of times patients have cell phones, but they didn't have for Doxy, they preferred using a Google Chrome and don't use the old Safari and, those types of things. And they didn't always have the most updated. And so we did find that sometimes that would cause a problem. I also found that some of my patients who do live in rural Oklahoma had trouble with connectivity. They had problems with having internet service that's consistent. And so sometimes it did make it difficult for them. But those patients usually were able to still do a telehealth visit with us because we've continued telehealth through most of the COVID pandemic. We stopped initially just because we didn't know and we didn't want to send staff out not knowing how to keep everybody safe. But then we were able to restart it and just put in the same protocols that we did in our clinic. So, but patients don't require having any of that technology. And we do try to try to hopefully, bridge that gap. They do have to be able to transport to the location we are. So even if we're in Poto or in McAllister, but they don't live in those towns. Sometimes I have patients who are living in smaller towns from there. They still have to travel to those areas. So there's still, it doesn't take travel completely out. So people still have to have a means of transporting and have gas money. But sometimes 30 minutes instead of traveling 2.5 hours is a big difference.
Great. I think we're at time. So any final thoughts from our speakers before we break for today? And just thank you again so much. Thank you for answering the questions and your thoughtful presentations.
Thanks for the great questions.
All right, thank you so much. We'll be sharing both a recording and slides following this session. And I think Mike offered up his email. And if we'll ask Dr. Ladd, if you have follow-up questions, we can connect you to the speakers to answer any other follow-up questions. So thank you again. Have a great evening. Thank you for bearing with us, and we truly appreciate your engagement. Take care.